then you click the screen.
Sure, and then I can do the button.
And then now you should be good to go.
Now, what did you guys have this morning? Multi-system trauma. So that was a review, basically, of everything else you've already learned, right? No?
Yeah.
I guess not. Well, today will be a review because they want me to do nervous system trauma, but of course we already did head, face, and neck trauma as well as spine trauma, and that's basically nervous system trauma, right? So a lot of this stuff we'll be able to blow through it pretty quick, and it'll be a review. So it'll be good for you guys. You guys can review it, solidify it, know it really well. We all learn from repetition, right? You guys were already tested on this stuff.
That might be why we're reviewing it.
Say what?
That might be why we're reviewing it.
Oh, really? Well, I mean, I gave you guys a lot of good hints for what was going to be on that test, right? You guys should have gotten
I got those ones right.
some of those.
Same hints.
What's that?
Very those same hints.
Yeah. Oh, really? I read the test.
He overheard you.
He said he wanted to talk about your teaching.
Sweet. All right. Well, let's go through it then. So competency, this basically just an integration of pathophysiology, anatomy, and then treatment and disposition for basically for a plan of an injured patient. We're going to go through central and peripheral nervous system. Of course, you guys understand what those are. And then anatomy and physiology of the head. We talked about that as well. We'll talk about the meninges. And you guys understand dura mater, subarachnoid space, pia mater. You understand where's the CSF? Arachnoid space. What does it do from a trauma perspective? Cushion. Good. So dura mater's outermost, pia mater's right up on the brain, right? Covers the convolutions of the brain and spinal cord. You guys know about the arachnoid space. We talked about the CSF. When you pull CSF out, or when you see CSF, what color is it? It's clear. Good. Colorless. Looks like water, but obviously it's salty. We talked about this as well, whereas the brain has 3 different components: blood, CSF, and matter, right? And if you lose one, or if I should say, if one is increased or one is increasing, the compensatory factor of the body, or the autonomic compensatory factor of the body, is to try to decrease the other, right? So cerebrum, that's the big portion of the brain, what most people would consider the brain. This is where you have conscious thought. This is where you have personality, speech, motor control, vision, auditory, tactile perception. All of that comes from the brain. And your face and your hands probably make up the greatest portion of your cerebrum, and especially your outer cortex. Or I should say your cortex in general. Outer cortex is probably a misnomer, because there's the inner portion of the outer cortex, which is between the 2 hemispheres. What's the cartilaginous divider in between? Good. And what's the divider between? That was a fairly aggressive high five. So What's the divider between the cerebrum and the cerebellum?
That's the. No, take it back. Take it back.
Everybody's nervous to answer because they're getting a high product.
That's what it is.
The tentorium,
Yeah.
right? All right. And why is it important to know where those are in trauma? You get swelling of the brain.
It's underneath that.
Yeah.
Causes
So
pupil bumps.
an uncal herniation, which is the most common herniation, that's where you're going to get the blown pupil. That's where your respirations will start to go down. You get that Shane-Stokes pattern. What is the uncal herniation? What is it diving down below? It's going into the foramen magnum. Eventually, it's going to start going out that hole, right? But it's diving down underneath the tentorium. All right. You have cingulate herniations that go underneath the falx cerebri. All right. So we talked about falx cerebri, central sulcus. That's the that's the division between the two hemispheres of the brain, right? And then the tentorium is that sheath dividing the cerebrum and the cerebellum. There those are again. Did you say what?
Yeah, it's like our side that has.
Really?
Should have known that before class.
Didn't you guys review?
I don't know.
So wait, what is your guys' slides called?
Safety, eleven, is not.
You don't have any nervous system trauma?
Yeah.
Just go into the spine and there's no head.
Unless it's way.
Well, let's see. So did yours go straight to?
Yeah, it's a spinal nerve.
On there, spinal column, nothing about the brain.
Don't have that slide. Maybe they didn't include that because it was all review. I don't know. So does yours go straight into that?
Nope. So ours goes from the
Introduction.
anatomy and physiology of the head, cerebrospinal fluid.
Straight to cranial nerves?
Yeah, right to opening.
Don't say that.
That doesn't make any sense.
Yeah, well, that was my good hand. I was able to get a full step. Yeah, it goes faster.
Okay. So this is where the cranial nerves is. Is your guys' a slide like anatomy and physiology of the head, cranial nerves? This one, is that where it goes into?
Yeah.
Yeah, we'll just have him upload the whole of it. So then you guys can kind of sit back and we'll just, I mean this, like I said, it'll be a review. And then when we start getting into the nerves, then hopefully it'll match up, but we'll get the rest of it loaded on. But honestly, there's nothing different from the combination of my other two lectures with the head, face, and neck and spinal trauma. And then this lecture, this is basically, like I said, just an overview and review, maybe from a little bit different source. Let's see. So you guys know this oculomotor nerve. Which cranial nerve is that? 3. Good. Controls pupil size. Controls pupil size in that which part of the nervous system is it really regulating? I mean, if you stimulate the oculomotor nerve, one, you've got ocular movement, right? So you've got all your movements of 3, 4, and 6. But when I'm talking about pupil, what does it do to the pupil?
Dilates it, shrinks. Controls pupil size.
Oculomotor specifically, what does it do? Think about it from a trauma standpoint. If you've got brain swelling and it shuts off the oculomotor nerve, what happens to the pupil?
It blows, it keeps them
So the oculomotor nerve normally constricts. Good. The sympathetic function, which is what would cause it to dilate, right, is outside of the brain. So it's not injured in a trauma setting. So that's why when you get brain swelling, the oculomotor nerve gets compressed, and you no longer have that constriction, and so you have uninhibited pupil dilation, right? So the two hemispheres of the cerebrum, and you guys, this is kind of more common knowledge when they talk about left brain thinkers, right brain thinkers, right? Your left brain is really your, I guess, the main component of most of your functions. So speech comes from your left hemisphere, math comes from your left hemisphere, all language, writing, understanding, speaking, that all comes from your left hemisphere. Right hemisphere is all your nonverbal stuff, so it's like creative thinking. Cerebellum, you guys know that. Cerebellum is coordination, right? Your gait. That is where your cerebellum is. Brainstem is, I mean, there's different levels of the brainstem, but big components of the brainstem is that this is where a lot of your spinal tracts are, and this is where your respiratory centers are, cardiac centers are, for breathing and for. So this goes through some of the components of the brainstem. But midbrain is where the hypothalamus and the thalamus is. Hypothalamus is where you have a lot of hormones that are secreted. And you get a lot of endocrine function from the hypothalamus. Hypothalamus sends signals to the pituitary gland. The pituitary gland then sends signals to the rest of the body. And the thalamus, this is considered basal ganglia, but this is where olfactory nerves are. When you have patients that have hypertension and have spontaneous hemorrhagic strokes, where they have uncontrolled hypertension and you have bleeding into the brain, it usually happens in the thalamus, the hypothalamus. Pons, but the pons and medulla oblongata are kind of right on top of each other, and this is where the pons, where you have a lot of communication with the CNS, the medulla oblongata, as we've talked about before, respiratory and cardiac centers. So just, I guess, a little bit of why. So the brain has a very high metabolic rate, and so if it doesn't have constant perfusion, it goes down pretty quickly. You start losing brain cells almost immediately when you have lack of perfusion. That's why time of strokes is so important. And that's why, you know, when you guys were teenagers, I don't know if you guys ever played that game of making each other pass out. You bend over and take some deep breaths and get back up, and, you know, you basically strangle yourself and cut off blood supply to your brain by pushing on your carotids, and you caused yourself to faint. I had one of my friends that I thought he thought it was so funny, and he I don't know if he got a high from it or something like that, but he would do it all the time. And that kid was already dumb as rocks. And I mean, he was losing. I mean, when we talk about brain cells, just a common fainting episode. Fainting is when you basically don't have perfusion to the brain, right? Whether that's a vasovagal response, you see a needle, you see some blood, you get that vasovagal response where you had that parasympathetic stimulation to your heart, slows it down into that automaticity where you get super slow heart rate, even down into the 20s and 40s, and then your brain isn't getting perfused and you'll pass out. I mean, that's what happens when people are like, oh, I feel faint, whatever. That's a vasovagal response to where the heart rate's slowing down temporarily. I mean, it'll catch back up, but you'll faint. Even those simple fainting episodes, millions of brain cells are dying.
What about like seizure?
Same thing with seizure. Well, seizure depends, because it all depends on if there's a decrease in respiratory function, oxygen, because the circulation remains the same. You're still pumping blood to the brain. It all depends on what's happening with respiratory function. So if you get a seizure where you're not moving air or that tongue blocks the airway, then obviously you're in trouble there. But most seizures, you still have respiratory function. There's just very few rare seizures where you lose respiratory function. So we talked about this before with the circle of Willis. Circle of Willis enables you to have perfusion to the brain from either side, right? So even if one carotid or one vertebral artery gets blocked, the other side can compensate for it, right? And then we talked about venous drainage, and it drains into the internal jugular vein and then into your superior vena cava, and that's why in circumstances where you have a tumor or a clot or something like that in the superior vena cava, or even like a tamponade situation, tension pneumothorax, where it's putting pressure on the heart, you'll get backup, right, into the internal jugular. You'll get backup. So that sometimes in some of those cases, tumor cases, I've seen some of those tumors. They're called Pancoast tumors, where they block off that superior vena cava, and their face, head, and certain parts of the neck will be red, and you'll almost see a line demarcated, and the rest of the body looks normal. And up above that level where it's not draining and you don't have venous drainage, it'll just look red. That reminds me, and we might talk about this a little bit later too, that question we had last time we lectured about neurological shock, and how when you have neurological shock, you have loss of vasoconstriction, so you have systemic vasodilation below the site of injury, right? And I talked about, in most cases that you'll have, basically kind of a red hue, a warmth there because you have vasodilation. I guess the misnomer there is that, one, you have a low blood pressure because you have massive vasodilation. So circulation isn't great, so it's not always warm as you would think it would be because your blood pressure is low. But in the cases that I've seen where I see that spinal shock or spinal injury and you have neurologic trauma, above that level of injury, you have vasoconstriction because the body's trying to compensate for that vasodilation. It goes into this, let's constrict everything down, let's get our blood pressure back, but only the vessels above that injury is working, right? So the face, which is generally what you're looking at when you're doing a physical exam and you're doing a general overview, the face will still look pale, ashen, that cool, clammy appearance. So it's kind of a misnomer. It's difficult to memorize it in just, neurologic shock is going to be, warm and dry. because it's really only warm and dry below that, the level of injury. Above it, it's going to be the opposite. Does that make sense? So blood-brain barrier, say that 3 times fast. The capillary cells, which is where all the epithelial cells are, and you can get movement between the blood vessels and the other tissues, right? That's where all your nutrients are moved and everything. That's at the capillary vessels. Well, in the central nervous system and in the brain, they're a lot thicker. So they don't let proteins through. They don't let a whole lot of things through that the rest of the body does. They basically let glucose through and water and salt. And that's what makes up your CSF. They can let some white cells through depending on what's needed if there's an infection. And that's why generally you don't have a whole lot of white cells in your CSF. Like if you do a spinal tap, there's not going to be a whole lot of white cells. If there are a lot of white cells, probably have meningitis, and you can differentiate between bacterial and viral. So we've talked about ICP. You guys understand the whole concept of ICP. The perfusion pressure is just how much pressure is needed to actually get blood flow, and of course this is auto-regulated through baroreceptors, right? Carotid arteries and other places. We talked about intracranial volume before. Traumatic brain injury obviously increases your ICP. ICP, intracranial pressure will then want to decrease the blood flow, and that's where you get this Cushing's response, right? Where you have 2 different kinds of signals telling the brain to do different things. And you have that cycle. We talked about that spiraling cycle. Increasing ICP causes your systemic blood pressure to increase to try to overcome that increasing pressure. You got a question?
Yeah, so yesterday we were kind of having this conversation, and Gary brought it up and said about ICP at D50. If you had with your patient and you were to give D50, he had said there's a correlation between that and raising ICP.
And raising ICP?
Something along those lines. But I guess I just was trying to get a little bit more enlightened on it.
It states it as a precaution in the pharmacology book and the drug profiles. So there's 2 sections. You can look at the footnote and you can go back and it's kind of more in-depth explanation of the drugs. And for D50, it does say that a precaution for administering D50 is a possible increase
in ICP. So it would be, if there was an increase, it would be temporary. Because anytime you have pure glucose in the bloodstream, what does the brain want? What's the only basic nutrient that the brain is going to get? It's going to be oxygen and glucose, right? So you give D50, your brain wants that sugar, especially in a state where it's not getting perfused very well because you've got increasing intracranial pressure. So if you give D50, the brain wants D50. What's the brain's autonomic signaling? What's it going to do to try to increase blood flow to get that glucose into the brain? So you can call those blood vessels to open up a little bit, right? To dilate and increase perfusion. What happens when you dilate those blood vessels in a patient whose pressure is already high? That takes up space, right? So that'll increase the pressure, but it's very temporary, because then the body is going to go, oh wait, we can't have this increased pressure. We need to dump that out. I mean, that's part of that cycling thing. So it would cause a temporary increase. But you also have, I mean, it's a you're damned if you do, you're damned if you don't kind of thing, because the brain also has a very fast metabolism, needs perfusion all the time, needs glucose all the time. So it needs the glucose. It's just that it has to, in order to get increased blood flow, cause a little bit of vasodilation, right? But oftentimes that's going to be depending on what your patient is doing and its respiratory cycle, how that CO2 is causing the brain either to vasoconstrict or vasodilate. You guys remember, if you have the patient's not breathing and you have increased CO2, what's that doing to the brain? Vasodilate. Good. And that patient totally goes into a respiratory, Shane Stokes hyperventilation state and dumps the CO2. What does that do? The opposite, right? Vasoconstriction. Vasoconstriction is also a problem because if you vasoconstrict too much, then you don't have perfusion. So then it goes back into the opposite state, and that's why you have this crazy hyperventilation, then not breathing at all. Then hyperventilation, then not breathing at all. Because the brain's not happy, doesn't know what to do. Either way, it's not getting what it wants, right?
So it's more related to the autonomic system and the brain's need for sugar,
Right.
as opposed to
Right. When the bloodstream gets a large quantity of sugar, the brain wants that, and the brain has constant perfusion. So when there is sugar in the bloodstream, the brain's vessels are gonna dilate and try to get that sugar, so that it can, like I said, it's got that fast metabolism. It needs perfusion all the time. It's always needing constant oxygen, constant glucose. So we talked about that increasing cycle, that Cushing's reflex means death is close, right? So this is about where your guys' stuff starts again, right? With the cranial nerves. You guys have all the cranial nerves memorized, right? What they do, what they don't do. All three? Cranial nerve 3 is important because that's one that you guys are going to deal with all the time, cranial nerve 3. All right, so understand that and where it comes from. Cranial nerve 7, what does that control? Facial muscles, good. That's going to be a very important one. Cranial nerve 10, good. What is vagus nerve? Parasympathetic, good. Vagus nerve is what part of the brain is it coming from? I should say vagus nerve is what causes, when you have that Cushing's reflex, vagus nerve is why the heart rate goes way down, right? Blood pressure goes way up, heart rate goes way down. Vagus nerve is what causes that heart rate to go down.
So then we only need to know those three. Okay, I know three.
Well, I would say those are the important ones. Let's see, from your guys' perspective. So what's this part of the brain? Brainstem, right? And vagus nerve comes out right there. So if you've got an uncal herniation and you've got brain pushing down through the foramen magnum, right at that upper brainstem, that vagus nerve is still active, right? So it starts to take out, all of this other brain function, but that vagus nerve is still active and it does not have anything that's opposing it anymore. So that's why the heart rate starts to sink down.
I have a question on that. The corticate and decerebrate responses.
Posturing.
Is there anything correlated between where it is causing a problem on the brainstem, high or low?
Mm-hmm.
What's the difference between those two?
So decorticate and decerebrate posturing is kind of those autonomic reflex responses where you get that muscle rigidity, and that's because there's not any opposing or controlling function telling it not to do that, right? And that's because higher function and brain is taking over. You've got herniation down through that foramen magnum, which means that all the spinal tracts that come from the brain and go down through the brainstem, see all those spinal tracts are going through this area all the way down. Anterior is more motor, sensory is more posterior. You can go into the details of which tracts are responsible for which functions. But as it starts to cut those tracts off, you don't have anything from the brain going down to the muscles and telling them relax or don't relax. So you don't have opposing function. And that's why you get, do you know which one happens first or which one happens later? Right, decorticate happens first, decerebrate happens last, and that's because of the area of where it is. Generally, you'll get pressure on the anterior portion first. Let's see. Anterior portion, flexor, extensor. Those are so close together. But you're correct. Decorticate happens first. That's the flexor. That means that there's no opposing force. I shouldn't say opposing force because there's still the opposing muscles, and they either both extensor and flexor muscles have that autonomic reflex, right? Just like when we talked about before, you touch a burning thing, you get autonomic flexion on one side and extension on the other side. And that doesn't require brain activity. That's quick reflex straight from the spinal cord, doesn't require brain. So when you cut the brain out, because the brain swelling's happening and you've got a herniation down through and you're cutting off those tracts and there's nothing going down into the spinal cord to tell it or to oppose that function. So that's why you get this autonomic reflexes that are not being shut off. Does that make sense? That's why you get that decorticate and then the decerebrate, and that's based on what kind of swelling is happening and what's being cut off first and what's being cut off later.
Is that why the Babinski test is effective with brain injury?
Yep. Let's see. You guys don't need to know that. Spine, this just kind of goes into the anatomy, and you guys certainly understand the anatomy of the spine. You guys have these slides? Okay, so from here on so far, you guys have that. All right, so you guys understand the spinal cord, where it is anatomically, right, in the vertebrae, and the spinal cord is all of those spinal tracts. If you can imagine, the nerve centers are up into the brainstem. That's where the centers of those nerves are. And you get a signal from the cortex of the brain, goes to the basal ganglia, where the hypothalamus, thalamus, basically where the midbrain is. So that signal goes from the brain to the midbrain, down to the brain stem, and then from the brainstem gets shot all the way down into the spinal cord, and those are just nerve tracks. If you can imagine, almost like big long nerves inside the spinal cord going down, and then they exit at certain levels of the spine to control certain things, right? The reflex tracts are peripheral, so they go from the muscle to the spinal cord, back out to the muscle, but those aren't tracts that go back up to the brain. There are tracts that go down from the brain to control some of those reflexes, so that when you have that reflex, it doesn't stay contracted, right? The brain shuts it back off after it's already happened. And that's why in decorticate and cerebrate, you get that reflex response, but the brain doesn't tell it to shut back off, so it stays like that.
Is it a separate pathway, or is it just...
It is, you mean the reflex pathway?
Yeah.
Yeah, so the reflex pathway is a separate nerve pathway. It's peripheral. It does go to the spinal cord and back out, but it's a reflex response, and there is inhibition from the brain that comes down. So those spinal tracts that come down from the brain will inhibit those reflexes so that they don't stay on. Does that make sense?
Okay.
So then in a spinal cord injury, wouldn't we still see some reflex ability of the body?
Yeah. So below a spinal cord injury, what kind of reflexes will you get? you would get hyperreflexia. So if you have like sciatica type patients where they have discs that are pushing on the spinal cord and causing injury to those nerves, they start to get pain, they start to get weakness, they start to get numbness in their legs. And if you do reflexes, like I hit that patellar tendon to do their reflexes, they have hyperreflexia. They'll like kick you in the face because they don't have that inhibition. At least they don't have great inhibition. Those cords are still kind of intact, but they're being damaged. So that's why they get that hyperreflexia. All right. If you damage the peripheral nerves, meaning the nerves that are already out of the spinal cord, in some back injuries or penetrating trauma, what kind of reflexes are you going to have? Already out of the spinal cord. Down or none, depending on how bad the injury is, right? So if you affect the spinal cord itself, you'll have hyperreflexes. Damage the nerves coming out of the spinal cord, already left the spinal cord, then you'll have decreased reflexes. All right? Regardless, I mean, both can cause weakness in the leg, but depending on where that injury is, will determine how bad the reflexes are. All right? Clear as mud. And you guys, that was extra knowledge anyway because you guys asked. All right? If you ask, it's going to be a big, long, explanation, and you don't have to know any of it for the test. It's just extra knowledge because you guys are such wonderful students. Right? Laban?
It's a Tuesday, I feel like.
All right, so reflex center intercepts sensory signals and initiates signaling to the muscle bodies. Does that make sense? You get a sensory signal, and then it automatically kicks back out to the motor. Doesn't have to go back up to the brain.
Is that like the bipolar nerves or the multipolar or whatever? Yeah.
Let's see. So spinal cord, same as the brain, always needs to be perfused, right? You can cause damage to the brain by either direct injury or indirect injury. Where does the indirect injury come from? Cutting off that blood supply, right? If you injure the blood vessels that are feeding the spinal cord, what kind of injury does that usually cause? What kind of cord syndrome? If it's a perfusion deficit. You guys remember this? Is it central cord syndrome, an anterior cord syndrome, or is it Brown-Séquard? Brown-Séquard is an a half injury, right? Where you injure one side of the spinal cord, and it causes different problems on either side of the body because of where those nerves that are coming down the spinal cord cross. Whether they cross up in the brain or in the brain stem, or if they cross right at the site where it's injured. So what happens then when you cut off the blood supply? Which injury is it then? If it's not Brown-Séquard, it's
Central cord, anterior cord.
anterior cord.
Central anterior?
It's an anterior cord. All right. Let's see. It does depend. In general, when you're talking about decreased perfusion, it's going to cause an anterior cord problem, just because of the way that the blood vessels innervate the spinal cord. The anterior cord is kind of the last one to get blood supply, so it's the first one to go. And depending on how bad that blood supply loss is, tells you how much of the cord is going to be injured. And then you'll get this kind of systematic loss of function. depending on how much, which neural cell bodies in your spinal cord are being injured. So when you're looking at that, the middle of this, is that gray matter, white matter? I'll just tell you, that's gray matter. And that's where do you think that's where your nerve fibers are or your cell bodies? Cell bodies is gray matter. Your white matter out here, what do you think that is? That's your axons, right? Why is it white? Myelin. Good. All right, so is this anterior, posterior, which side? What is this? Anterior. Good. All right. So you can see your nerve roots leaving the vertebra. This is let's see. Okay, so we talked about that. White matter, axons, ascending tracts are signals back to the brain. Descending tracts, signals from the brain down to the cord. Let's see. Spinal meninges, the same. Dermatoarachnoid, pia mater. We know where the cerebral spinal fluid is. This is the epidural space. That's where you get epidurals. They come in, they access that space, send in a whole bunch of lidocaine or whatever that they're using, marcaine. Sometimes it's constant drip. And
How big is that space? Like when you're doing a spinal tap and they come at you with that freaking ridiculously long needle.
right. So spinal tap and an epidural is different. Epidural gets to that space but doesn't go into the spinal cord, right? So they inject all the medicine right there, and it gets it diffuses this way and this way. Sometimes you'll see those ladies that are getting an epidural and they're like, "Oh, it's working great on the left side. I'm getting nothing on the right side," and that's because their tube is kind of they get into that space, but it kind of tunnels over this way, and so it works great on this side. It doesn't do anything on this side, right? So my wife, our first child, she had an epidural, and she felt like she felt everything, and that's because. But then when she got up afterwards, she had like no function in one leg, and it worked great on one side, but didn't work on the other side, which didn't necessarily help her for the birth, right? Yeah. It is a very precise injection. But do you know what the conus medullaris is? Does that sound familiar to any of you? Conus medullaris is where your spinal cord comes down to an end. All right, it's where the spinal cord ends, and that's at about. Do you guys know where? L1, L2. And that conus medullaris, the spinal cord comes down to an end, and then after that, it's just nerve fibers. And there's no spinal cord in that. There's no gray matter. There's no white matter. If you stick a needle into the spinal cord, you're going to mess up all sorts of stuff, right? You're sticking it right into definite nerve tracts, and you're sticking it right into neural cell bodies. So you're going to damage everything distal to that, just like if they were stabbed in the spinal cord, right? But if you stick a needle past the conus medullaris, there's only nerve tracts, then you've got some wiggle room. You're going in between nerves. You're not going into cell bodies. Does that make sense? So when you're doing a spinal tap and you want cerebral spinal fluid, you're going past that subdural space and you're going right here. You're also, oftentimes you go too far and the patient's like, "Oh, I can feel a shock down my left leg." That's not permanent damage. That's like hitting a funny bone. And so, you pull that needle back out a little bit and you can get the drip and you get that cerebral spinal fluid without sticking it into the spinal cord. And that's why we go lower than L2 or L1, L2. We go L3, L4, L4, L5, L5S1, those spaces. But we're not going into the spinal cord, we're going into the nerve tracts. Does that make sense? And the same thing with an epidural is they're doing that epidural below the conus medullaris. So they're not going into cell neurons. They might, same thing with an epidural. Sometimes they go too far and the patient's like, oh, pain, left leg, pain, right leg, whatever. Then they back out and hope that gets better. Spinal meninges, spinal nerves, you guys know, peripheral nerve tracts, sensory and motor. Let's see, the different plexuses, or would it be plexi? I don't know. So you got brachial plexus, you got your lumbar plexus. Dermatomes and myotomes, are they the same, different? Different parts of the body? Right, so if you take out a dermatome, does that necessarily take out all the muscles in that dermatome?
No.
No. Good, there's overlap in the myotomes, right? Not a whole lot of overlap in the dermatomes. All right, we talked about reflexes and the need for reflexes and the speed the body's response to get out of trouble. Parasympathetic and sympathetic, you guys understand those. TBI, so any brain injury is anything producing physical, intellectual, emotional, social, vocational changes. Which doesn't mean that, you know, if you hurt your wife's feelings, you cause traumatic brain injury. This is brain injury where it actually causes emotional changes because of damage, physical damage to the brain.
Hurt your wife's feelings when she's like mean to you for the rest of your life. Is that a traumatic brain injury?
Yeah.
Another class.
They don't forget. It's crazy that they don't forget. And me, like, I'll be like, oh, I'm totally going to use this later when she wants an example of, you know, that she, you know, you'll have an argument, be like, well, you always do that too. And she'll be like, oh yeah, well when? And I can't think of one freaking damn example. When it happens, I'm like, oh, I'm totally gonna remember this. An hour later, I don't remember it. But she'll remember it for freaking ever. And she'll be able to like list all the things that I did. I'm like, well, I know you did it too. I just can't remember when and how. I just know that you did. Damn it! It's ridiculous. All right, we talked about the jarring coup injuries. That happens from direct impact, right? Contra Q is the opposite, sloshing of the brain, the other side. Talk about. I like how it gets smashed with a rock. It's like David and Goliath right here, right? So what did Goliath die from? Q and contra Q injury. He died from DAI, I'm guessing. Maybe epidural, subdural. I mean, he probably had intracerebral hemorrhage as well.
It went in his head. I mean, it was so in there.
That's true. All right. So focal injuries. Hurt in a specific location. This is your cerebral contusion, blunt trauma, local brain tissue, capillary bleeding into the brain substance. You guys lose it?
Yeah.
Did you get this one?
No.
So where did you lose it?
Traumatic brain injury was the last, that one.
That one?
Oh, God.
And you lost all of this?
Yeah.
Well, it's a good thing that you guys have already learned it. We'll get you the lecture. So you don't have this? So where does it start up again for you?
Damage to spinal phases. Initial damage, secondary injury, and then different spinal cord injury.
Spinal cord. Okay, so this is brain injury, and you guys start up with just spine.
Yeah.
All right. So they didn't want in your guys' PowerPoint. It's like all spine. It's just all head or all it's all spine, no head. All right. Well, we'll get that. I'll talk to Gary. You guys already know all this stuff anyway, right? Q, contra Q, epidural hemorrhages, subdural hemorrhages. Epidural hemorrhage. You got a patient with an epidural hemorrhage. How is he going to present?
It's going to be rapid and quick.
Rapid and quick. Initially, is he going to be knocked out?
No.
What is he going to do? Yeah, he's probably going to be fighting you. You're like, I'm fine. I'm out of here. Let me get up. He's going to try to walk away. And then all of a sudden, right, he's out. Subdural hemorrhage. What's the age group that generally happens? Elderly. Why is that? One, they fall a lot. Two, they have blood thinners. Three, and probably most important, is their brains are shrunk and they have a lot of room in there to slosh around. It's not that they have a lot of room for the blood, because that doesn't differentiate it from an epidural, right? The fact that they have a lot of room is the most important, because there's room to slosh that brain around and tear veins. Tear those veins, and then you get those slow bleeds that happen over weeks, days, whatever. So there's your epidural. And you guys saw that on previous lectures, right? You understand where that epidural happens outside of the dura mater, right? In between dura mater and skull. What's the common artery and place for an epidural hemorrhage? Temporal bone. That's because the temporal bone is thin and weak. And what's the artery that runs through there? You would think. It's the middle meningeal artery. Subdural hematoma. You guys know what a subdural is. We just talked about that. That is in what space? Good. Subarachnoid space. Yeah. Intracranial hemorrhage. That's the hemorrhage that's just right in the middle of the brain, right? Why does that happen? For the most part, can't happen in trauma. Also happens because of basically hypertension and causing an aneurysm to burst, or spontaneously. There doesn't have to be an aneurysm there, but it's going to happen a lot more likely if there's an aneurysm there. An aneurysm is usually there because of bad genes, right? Blood loss is minimal. It's very minimal bleeding, but minimal bleeding into a very, very important area. Stroke out. Diffuse injuries, we talked about that. DAI is basically a form of concussion, right? Your classic concussion is what level of DAI? You guys remember? Classic concussion, meaning that you're confused, might have temporary loss of consciousness, you've got amnesia.
Secondary or
It'd be like a moderate DAI, right? Concussion, mild to moderate, DAI, transient episode of dysfunction, confusion, disorientation, amnesia. The moderate DAI, where you start to actually have injury, that's your classic concussion, what we just talked about. Oftentimes you have associated basal skull fracture.
Is there a difference between confusion and like DAI? contusion? Is that the same thing as DAI?
A contusion can cause a DAI, but a DAI is more of a diffuse brain injury from swelling. A contusion is more of a focal bruising, but that can then cause a diffuse swelling. Does that make sense? So it ends up being the same thing, but the definitions are a little bit different. So severe diffuse axonal injury, that's when you have real disruption of the axons, and that extends into the brainstem. Patients usually do not survive from severe diffuse axonal injury. We talked about that that patient last time that I had fell off a golf cart, severe diffuse axonal injury. And we talked about this, of course. The increased ICP causes hypoxia to the brain. The hypercarbia comes from those decreased respiratory centers, patients not breathing, and you get CO2 buildup that then causes increased ICP again, right? What's the reflex called again? When you get severe DAI or herniation, Cushing's reflex. What are the three parts of Cushing's reflex?
Heart rate, increased blood pressure, and erratic respirations.
Okay. I think I heard most of that, but decreased heart rate, increased blood pressure. What happens to it's increased systolic blood pressure, right? Diastolic doesn't necessarily follow suit, and you get this widened pulse pressure, right? And then Cheyne-Stokes respirations as well. Good. Because your brain can't figure out how to regulate this pressure, so you go into these periods of breathing too fast, not breathing at all, blah, blah, blah. All right, we've talked about that. So this is the carbon dioxide, low levels of carbon dioxide. Hypocarbia triggers cerebral arterial constriction. That constriction gets too bad, then the brain tells the body to what? Well, hyperventilation generally causes the hypocarbia, right?
Stop breathing.
Yeah, and that's when they go these apneic spells, right? Oh crap, they stopped breathing. Well, that's the brain trying to build up that CO2 again, because there's too much vasoconstriction. It's not getting blood flow. They try to get more blood flow, but there's not any more room in the brain anyway, so that doesn't last for very long. They'll go right back into hyperventilation. Let's see. So with injury, obviously hemorrhage accumulates, edema happens, herniation, that's portion of the brain structure pushed into another space. Uncal herniation is probably the most common, and that's herniating underneath the tentorium down through the foramen magnum, right? We talked about that. Central cord syndrome. So upper brainstem compression. This is kind of an example, but that'll cause that Cushing's reflex because you get that increase in the blood pressure to maintain the perfusion. I mean, this is just all about the. This isn't central cord syndrome, so don't get that mixed up. I don't know why they called this central syndrome. I think you could basically cross that out and call that Cushing's reflex, because that's what we're talking about right here. Central syndrome might be just an older term used to define that. But don't get that confused with the central cord syndrome, because it's certainly not the same thing. Middle brainstem, lower brainstem, pupils fully dilated and unreactive. That's because which cranial nerve is compressed? 3. Good. Patient no longer responds to painful stimuli. Skeletal muscles are flaccid. Patients, so that's when they're just unresponsive, but they don't yet have that decorticate and decerebrate, right? But it's coming. So we talked about pediatric head trauma before. Why is pediatric head trauma, or why are ped patients probably better suited for head trauma than adult patients? It's not ossified, right? So those skull bones move a little bit. They've got fontanelles, so they've got space. They've got more room, and that kind of goes along with just evolution and the I shouldn't necessarily say evolution, but the reason why kids don't have ossified skulls when they're born. One, to get out of the birth canal. Otherwise, if they had ossified skulls, they'd never be able to get out. But 2, kids' coordination doesn't really set in until 5, 6, 7. They start to get coordination at about 3. And when they're 1 and 2, they start walking around, but they're not very coordinated. They're falling all the time, right? Kids are hitting their heads constantly. My kids always had bruises and bumps and everything, and always looked like we were beating our kids. But that's because they were uncoordinated little crapheads. But there's a reason why that is, and that's because they hit their head all the time, and we don't want them to have brain injuries. And they don't get the concussions because there's give. All right, so we talked about fontanelles. In kids, and the difference from adults is if you get bleeding into a kid's head, you can still have hypovolemia. You can still lose a lot of percentage of their blood in their head, whereas adults, that's not going to happen, right? Spinal phases is where you guys start again? All right. Let's see. So the initial damage is the direct impact, or the hemorrhage itself, right? The secondary injury is if there's something in the vicinity, like you get hit in the back or you get a injury to the back, whether blunt trauma, penetrating trauma, whatever, bleeding into the area or swelling in the area can then cause pressure put on those nerves. That's the secondary injury. Does that make sense? So concussion is that temporary transient disruption. That you can have a concussion of your spinal cord. That's temporary, right? It comes back. Contusion is the bruising of the cord. You actually have tissue damage. Contusion can cause concussion-type effects, but the contusion itself is damage to that focal area. But a contusion generally is not terrible injury and usually can heal. Not always, but usually can. Compression, obviously, this is compression onto the cord. If you have restricted circulation, how is that going to cause compression? Or ischemic damage. What's ischemic damage? I mean, that's kind of the same thing as restricted circulation. What's ischemic damage? No blood flow, right? You're not getting any oxygen. You're not getting any blood flow. So it happens with a stroke. You can have a clot or an embolus go to the spinal cord. You can have a clot or an embolus go to the brain. That can happen with AFib patients, right? They're sending out clots. They don't always have to go to the brain. They can go to the body as well. And can get up and clot any blood vessel. So then how can you get compression injuries from a blood clot? This is why in stroke patients we don't just put them on warfarin or put them on Eliquis or Xarelto or other serious anticoagulants. Why wouldn't we? They're having blood clots. We don't want them to have blood clots anymore. Why wouldn't we put them on a serious blood thinner?
Clot goes and blocks up the vessel. Pressure back up behind it.
It's not because of the pressure back behind it. It's because anytime you have dead tissue or tissue that then becomes damaged and is dying, like what happens with a stroke, you don't have any blood flow, you don't have any oxygen, that tissue starts to die. When that tissue starts to die, it releases proteins, cytokines, those cells become broken, all of the stuff that's inside the cells gets released. That tells all of your immune system to come to that area, and you get swelling, right? You get edema. So after a patient has a stroke, all of that brain tissue dies, but then they get swelling and edema and continues through the rest of the brain tissue. So it doesn't just kill that area. It can start to, depending on how much damage there is, there can be edema and swelling. So that's why we're like, with stroke patients, we don't always know how much of a recovery they're going to have, because they won't recover from the dead tissue, right? That's not going to recover. They could recover from the damage from the edema and the swelling, because that might come back down, and we don't know how much back they're going to get from that area. If you put them on a serious blood thinner, that's a vulnerable area, right? They'll bleed into that area where they have the edema and that injured tissue. So that's why you can have compression issues from ischemic damage. Does that make sense?
So it'd be like secondary damage for
Yeah.
clots as well.
Yep, exactly. Laceration of the spinal cord generally isn't from direct stab or something like that, although it can be. Most of the time it's because of broken bones and broken fragments that are going into the spinal cord and tearing and causing lacerations. Obviously, it depends on how bad that laceration is, on how bad or how much healing you're going to have. Hemorrhage, we talked about that in spinal cord injuries, transection, complete transection, obviously, lack of function from that side of injury down. Usually happens in the thoracic and the lumbar spine. If it happens in the thoracic spine, you get paraplegia, right? All the way up to what level? When does the brachial plexus end? C7-T1 space, right? Or in some patients, C8. But so from about T1 down, so the T1, T2 space, T1 down, you'll get paraplegia, right? So you can get an injury all the way up here. You can't feel anything from here down, but you can still move your arms, right? If you get an injury of the neck, of course, that's going to start causing quadriplegia, arms and neck. Hemiplegia is what? One side or the other. Good. You can get hemiplegia from what kind of cord syndrome? Brown-Séquard. Good. And on the other side, so you lose sensation and motor on one side. On the other side, you lose what? Pain and temperature. Good. So you're kind of in a bad spot. One, you can't feel anything on one side of the body. The other side, you can move, you can feel touch, but you don't feel any pain. So you're at increased likelihood of injuring your only good side. All right, spinal shock. You lose spinal reflexes, and affects all the muscles innervated below that. Acute phase from certain spinal cord injuries, but you can get respiratory insufficiency depending on how high it is. These are cervical cord injuries, quadriplegia, absent upper and lower extremity reflexes, depending on where the, I think that is somewhat, I mean, that's somewhat incorrect, depending on which tracts are injured in the spinal cord, because you'll still have your peripheral nerves, and you can still get some reflexes. But once the cord itself doesn't have any tracts, the cord function is gone. All right. Last, lack of rectal and bladder, sphincter tone. So that's acute phase. Subacute phase, muscles become flaccid, spasticity develops, then you start to get that hyperreflexia. So in the acute phase, your reflexes are gone. It's like you get this spinal shock to your cord, and it stops sending signals in general. But then the subacute phase, when your spinal cord or your other peripheral nervous system starts to realize, well, I can still function, you get that autonomic hyperreflexia. The cord shut off, there's nothing to tell those reflexes to stop, and you start to get that hyperreflexia. You get spasticity, and that's why patients will get rigors. You know, those patients that are quadriplegic, their muscles will atrophy, but they also get rigors, and that's that decorticate, that same decorticate. Yeah, they get those contractures, and they get that same thing that happens with brain injuries. They get those decorticate and even sometimes decerebrate, depending on where their injury was and how they get that spasticity.
How strong will that be?
Those contractures?
Yeah.
Super strong. Those muscles get contracted down, and the problem is that they become hyperreflexic, and those muscles flex, and they get that decorticate, and that stays like that because they have nothing that can relax that, and then over time those muscles will, that's why they call it contractures, those muscles stay contracted down, and they lose elasticity in the tendons. So if you try to break that, then you're tearing tendons, you're tearing, and you know, all the other stuff. So that's why, like, if you hurt your shoulder or you hurt your knee or you hurt your leg, you don't move it for a while, it stays in that position for a long time. If it stays in that position for too long, you're not going to be able to extend that back out because all your tendons tighten up. They get used to being in that position. And so, and then when you try to extend it back out, it's really tight. You have to go through physical therapy to try to loosen all those things up again, stretch your tendons back out, stretch your ligaments back out.
Do their joints begin to ossify at any point in time? Or do they just kind of stay?
No, at least not that. Well, I don't know. When I've taken X-rays of patients with contractures, their joints appear relatively normal. They'll get arthritis, but the arthritis doesn't do anything because they don't move that joint. Really no. And generally, they don't even get that much arthritis because there's no wear and tear. They're not moving that joint. So we talked about the cord syndromes, anterior cord syndromes, where you get fragments, pressure, something compressing the arteries, and you don't have perfusion to that portion of the cord. Central cord syndrome, that happens from hyperextension injuries. And it causes trauma and shock to the central part of the cord and expands out from there, depending on how bad the injury is. It depends on how bad or how extensive that cord is. The last thing to go in a central cord is going to be pain, because that's on the outermost portion of the spinal cord. Those tracts are on the outermost portion of the spinal cord. So you'll still feel pain up until the very end, which is kind of a dirty trick, right? Brown-Séquard, we talked about that. Cauda equina, that's a peripheral nerve injury. Those are nerve roots. Cauda equina happens with bad sciatica or bad herniations pushing on the nerves. It can cause and it can cause, bad caudate equina is bilateral, pushes on both sides, so they lose bladder function, they lose rectal function, they get weak, and sometimes, like paralysis type state in the lower extremities. So that's why, if a patient comes in and they're like, all of a sudden I can't move my legs and I can't hold my bladder, we need to get them to a neurosurgeon quickly to try to relieve that pressure so that that doesn't become permanent. And sometimes back patients, pain patients, it's difficult, right? For you guys, you get these back pain patients, and it seems like every other week they're telling you they can't move their legs or something new has happened. They want to go to the ER. Their goal is sometimes to try to get pain medicines, but you got to take every single case seriously, right? Walk in with a smile. Neurogenic shock. You guys know what happens with neurogenic shock, why it happens, right? It's all about vasodilation and causing hypotension, right? What's the easy fix? Dopamine. Good. So this is, I would say, a little bit later that happens with neurogenic shock type situations as the body starts to adapt and tries to get control of that hypotension. It'll go into this hyperactive state, and it can cause seizures, strokes, death. Strokes because everything above that injury, it'll really try to clamp down. It's trying to vasoconstrict everything, but as it's vasoconstricting, it's only working on what's up above that injury, right? And if it vasoconstricts too much, and you can get strokes.
How long after the injury does this happen?
It's a phase of neurogenic shock, and if it goes untreated, they can either die from hypotension, right? Or if they're getting just enough blood flow to the brain that they're not going to die from the hypotension, this will start to set in if you don't get the dopamine, if you don't fix the shock itself. What else can you do besides dopamine with neurogenic shock? Epi. What else can you do besides vasopressors? I mean, the vasopressors is the answer, right? At some point, you're going to need epi or dopamine, vasopressin, whatever. But to try to help with the hypotension itself, what can you do? Fluids. Yeah, you could give this patient a 2-liter fluid bolus. Try to help with that. Stinger. You guys remember what a stinger is? Generally happens with sports injuries. Happens with basketball players and football players, for the most part. Basketball players, they're pivoting. They pivot over to the side. They nail a guy that's coming in. It hits their head, and they get this traction pulling injury, and they get a stinger, where they get kind of a pinching or damage to the nerve, and it can cause transient quadriplegia. That patient could just drop. Like, I can't feel my arms, can't feel my legs. 30 minutes later, they start to get that stuff back. And that's because it was a bad injury, a bad impact, but it's transient. It didn't cause a transection or anything like that. You hope for a stinger if you're going to have a nerve injury.
And I'm sorry, that's just because where they got hit on the head, just compress that nerve just temporarily. Is that kind of correct?
Right.
It feels like it's like a severe hitting your spine, but it hits you right here.
Oh, in the neck, so it's in the neck,
Right.
not in the head.
So it happens mostly in sports. It can happen from motorcycle accidents. So like my brachial plexus injury, the most or the best injury that you can get from a brachial plexus injury would be a stinger. You get injury to the spinal cord, to the brachial plexus, but it's an impact injury where it causes very transient cessation of neurologic impulses. but it doesn't actually cause damage to the axons or myelin sheath. So over time, 30 minutes to an hour, maybe a couple hours, that stuff starts to come back.
Like maybe it's stun it, or I guess I'm trying to like it's stun the nerve or whatever.
Yeah. So it's like a, you get smacked in the head, and you're like, for a second, you've got to kind of catch yourself. Okay, where am I? What just happened? You kind of lose sight. Well, that's similar to what happens with the nerves, is that you get that sudden impact, and it doesn't cause axon injury. It doesn't actually cause myelin to die, but it causes an impact to that specific location to the point where that nerve stops sending signals until some of that swelling and things start to go down, and the nerve realizes, oh wait, I'm okay. I can start sending signals again, and it starts to wake up. You guys ever heard of Saturday night palsy? Where you get drunk, you fall asleep on a chair in your armpit, and you wake up the next morning and you can't extend your wrist. It's a radial nerve palsy. And that's kind of like a stinger, but it's a little bit more serious than a stinger. It's a compression injury that hopefully will improve over time depending on how long you compressed and injured that nerve, right? I see that all the time in the emergency department. Sunday morning, patients come in and be like, I don't know what happened. I think I had a stroke. I can't extend my wrist. What happened last night? How did you sleep? Blah, blah, blah.
Fell asleep on my arm.
Yeah, exactly. All right, so you can get injury on anywhere along that nerve path and cause the same effect, right? But you have to figure out where along that nerve. Did it happen in the spinal cord? Did it happen in the peripheral nerves? And where in the peripheral nerves? So it takes kind of a dedicated neuro exam to try to figure out where that happened. An injury affecting a single dermatome usually is created in the vertebral column. It can happen peripherally, depending on how bad you injured a nerve and what was threatened. So again, kids, they have a lot of mobility and a lot more elasticity. It takes a lot more trauma to injure a kid than it does an adult. Kids will often walk away from car accidents uninjured, where adults have whiplash and everything else and have lifelong back pain, etc. That starts to change at about 10. Then they start to get more responsive like adults. But from 2 to 10, that starts to become less elastic. Let's see. This is, you guys don't need to know that.
That last slide said the young spinal column will stretch but not break.
Yeah, so this is where, because kids have a lot of elasticity, you won't actually get any changes on the X-ray. Meaning they could be in a serious accident, and you'll look at the X-rays and you'll look at the CT scans, and they'll look completely normal. But there still was damage or injury because they stretched that spinal cord. But because all their ligaments, tendons, their bones are more flexible, less ossified, you won't have any fractures, you won't have any displacements, and on radiology, they'll look completely normal. But they'll still have neurologic symptoms, and you kind of go off of mechanism of injury. They're still at risk for significant injury. So you have to take them serious. Any kid that's complaining of any neural symptoms, you have to take that seriously because it takes a lot more to affect the nervous system. And the radiographs in their spine and everything else will appear normal. They'll still have nerve injury. Does that make sense? So scene size up, mechanism of injury, right? Take any possibility of nervous system injury seriously. be ready for internal brain and spinal cord injuries, even if externally they appear okay. So this is, we talked about the immobilization of a standing patient, but getting the backboard behind them, obviously getting a lot of people on board, keeping the patient stable, and doing that standing immobilization. For some reason it doesn't connect to the video. Our hyperlinks are messed up. And Doug and Gary have been trying to fix that for a while. So you guys know your primary assessment. For a neuro exam, obviously knowing loss of consciousness is important. Asking the patient, did you lose consciousness? Do you remember? Everything. Always suspect brain injury, and examine mental acuity. Try to get a pulse on what their mental acuity is and the trends of that mental acuity. Facial skin color. That's going to be important for spinal cord injuries. Why? We talked about this earlier today.
Oh,
Yeah, the face will look what in a neurogenic shock, in a spinal cord injury, a transected spinal cord. Yeah, the face is going to look ashen, pale, clammy. The face is going to look like death. The rest of the body looks pretty good, right? Skin looks good. You feel their pulse, the radial pulse, and you're like, well, their hands are warm, whatever, but their face looks like death. You're like, oh crap, we got to be really careful with this one. All right, so this is just a simplified motor score. Obeys commands, 2, localizes pain, 1, withdrawals to pain, 0. Score of 0, you tube them. Score less than 2, you're going to a trauma center. You're worried about neuro and head injury. All right, so primary assessment, obviously airway, consciousness. Does the patient withdraw to painful stimuli? You're doing all of these quick assessments. Closely monitoring the patient's breathing. You're doing repeat exams all the time. Hypoxia and carbon dioxide retention both contribute to morbidity and mortality in a brain injury patient, and we talked about why that is, right? Ventilations, you're watching capnography really closely in any kind of brain injury patient, right? You set up that end-tidal CO2 right off the bat. Get them on oxygen. Monitor their pulse carefully. Repeat blood pressures every 5 minutes. Let's see. Obviously, you want to control bleeding. Recognize signs of cerebral herniation with Cushing's reflex. We talked about that. This is all review from that. Herniation, you can get singular or bilateral dilated fixed pupils. You get bilateral, that's worse than even singular. And then you get the posturing. Right before the posturing, you'll get kind of this flaccid response, right? They're not moving anything.
Is it like a slow, gradual thing, or does it happen suddenly?
When they start to herniate, that happens. You'll get all of those responses within about 5 minutes.
Do they go from flaccid to super?
No, that'll happen more. That'll happen slowly. So you want to start to notice that in their ankles and in their hands. Trauma assessment. You guys know all of this back and forth. We've talked about trauma assessments and primary assessments. Talked about pupils, spinal cord injury, skin beneath, flush and warm, skin above, cool and clammy, loss of nerve control below injury. They can't compensate for the shock. Line of demarcation, right? When can you feel this? Can you feel this? Can you feel this? So when you're doing your trauma assessment, you're doing that really quick. You're starting from the bottom up, push down on my hands, pull up on my hands with their ankles, then you're going up their legs. Do you feel this? Do you feel this? Do you feel this? You get up to the upper body. You have them squeeze your hands, and you still go up with the sensation. You feel this? You feel this? You feel this? And of course, if they're saying no, then you want to be a lot more careful on what you're doing as you're going up. So you try to find where that level is. And then it's usually very demarcated. I feel that. I don't feel that, right? Because of those dermatomes. So yeah, begin with your feet, work upwards towards the head. Use sharp objects, obviously not to cause pain, but you can use fingernail. You can use. I always use the back side of the reflex hammer, but you guys don't have reflex hammers on a Paramedic. But you can use, the back side of Q-tips. I often break. You guys have Q-tips. You guys don't have swabs or anything, Q-tips, nothing like that in there. You don't want to use a needle. Yeah, you could use a pen lid or the back side of the pen, just kind of a sharp edge of plastic. You just kind of go up. Yeah, that would work just as well. Let's see. If you start to notice differences where they have difficulty in motor, then you can start to examine, more closely. Do you guys know upper body how to examine ulnar, median, radial nerves in the hand?
Well, I have tennis elbow from lifting the gurney too much, so I have compression on my ulnar nerve, and these 3 fingers go numb. So, like right now, I'm tingling in these 3 fingers, and I'll lose sensation in them. So I have compression on
your ulnar nerve.
So that's what I know about it.
Right. So that goes along with the dermatomes, right?
Yeah.
Ulnar, radial is the back of the hand and kind of wraps around the middle finger, and then median is over here, and that's what, 6, 7, 8, right?
6.
Yep. 6, 7 is extension, middle finger, and then 8. 6, 7, 8. But you can do certain things with the hand. Give me an A-OK. That's median nerve. Touch your thumb with your pinky. That's ulnar nerve. Extend your wrist up. That's radial nerve. So you can kind of differentiate and see if they have some function, if they don't have some function. Now, is that extremely important for you guys in pre-hospital? Not, but can certainly be helpful to know if a patient did have this function and then now they don't by the time they get to the hospital and the doctor's examining them. You can say, oh, the patient was able to do this, able to do that, able to extend the wrist. And the doctor said, well, they can't do that now, so we've got an ongoing compression, possible bleed, whatever that we need to fix real quick. All right, let's see.
Carpal tunnel, is that like nervous?
Carpal tunnel is median nerve. So carpal tunnel is because your median nerve runs right underneath your retinaculum in that space, and because you're doing certain movements too much, you cause inflammation and injury, and it starts to compress that median nerve at your wrist. And you generally get pain and problems in these 3 fingers. These ones are spared because that's ulnar nerve. So we're just going through, so testing the Babinski, we talked about that. What's a normal Babinski? Curling your toes, right? Good. That's the Babinski. See, that's the back side of the reflex hammer they usually use. But your pens work great too. Fingernails work great, especially if you don't trim real well. But obviously, most of the time if you're touching a patient's foot, you want to have gloves on. All right. Trauma assessment, EKGs, obviously something that you want to do early. EKG is so informative, more so than just problems with the heart, but any kind of change in EKG tells us and can tell you a lot of other things, right? It can tell you if you're having a PE. It can tell you, now I can't think of all the different examples, but think of an EKG almost an extension of your vital signs. If you can, if as soon as you can get an EKG, get an EKG. All your, okay, tox, hypo, hyperkalemia, I'll think of all the different EKG things that you can get otherwise. But all right, so this is more of the same. You guys know about Glasgow coma scale. Did you guys feel pretty comfortable with the GCS? You guys had a lot of questions on GCS, right? Now, I told you you were going to, didn't I? Were you ready for those? All right.
I don't know how he's going to grade it, but if you're within a point, is that close enough? Because some of the stuff that I studied didn't have like the flexion to pain on the test. That might be a question.
You mean just localizing the pain?
Or he would say they
Yeah,
withdrawal
you would say
Withdrawal.
action or withdrawals from pain.
Because there's local withdrawal from pain, so local flexion, and then there's kind of generalized flexion with pain.
He didn't specify that. It would just be like he's flexing.
I'll talk to Gary about it. We review the tests. I don't review your guys' tests scores at the end, but I review the test questions with him. I'll talk to Gary about it because, yeah, GCS really is subjective and it's not always an exact science. The questions that he asked should have given you an exact number, but if you guys have sources that aren't giving you those differences, in my mind, within a point is, especially clinically, within a point, you're good. You're good enough. So I'll talk to him about it.
That's my question. So if he says they withdraw from pain,
I think
I'm
that's it.
thinking higher up, and then he says withdrawals with flexion, then I can lower down.
But it's
you know.
withdrawals.
But it's, yeah, so do I err on withdrawal or do I err on flexion because that's worse than just withdrawing from pain?
That was that.
That was,
Oh,
Yeah.
so on the question it just said withdraw from pain, or did it say flexion?
with flexion.
Withdraw
Withdrawals
with
from
flexion.
pain with flexion.
Yeah.
So that would be worse, right?
Yeah.
That's not,
That's not on the scale.
So would you give a,
later in the
that's my
question.
Saturday, was that a 3 or a 4?
Right.
Or,
I heard
It said his whole body was cut.
Right. It should be,
I don't know. I erred.
decorticate and decerebrate is diffuse, right? So if you've got localized flexion with pain, that's better, right? That's your higher number. I'll look at it. I'll look at those questions specifically again and see if there's confusion there. All right. We talked about that. Patient questioning, headaches, light sensitivity, amnesia. So ample history. Do you guys go through ample history? When you guys are history taking, you go through that acronym ample to try to remember all of it, right? Okay, good. As you remember this, history is so vital and important, especially, obviously, it is with your patients, because there are pieces of history that if you don't get, you'll treat the patient wrong, right? And with Gary and with Doug, when they're doing your guys' oral codes and running you through SimBan things, if you don't go through ample, you're going to miss stuff, and you're going to screw up the whole case. So always remember to go through your history and go through that ample acronym. So reassessment, anytime you have a neuro injury, you want to do constant reassessment. We've talked about that before. Recovery position with head injuries, put them at about 15 to 30 degrees. That's not going to cause lumbar or increased lumbar injury. You don't have to worry about that. All right, you guys know how to mobilize lying patients. You guys we run through those drills and labs and everything else. Okay, open neck injury, danger of air embolism. It says to place the patient in Trendelenburg. Technically, in the books, that's what it wants you to do with a brain injury patient. If they have a neck injury, you're worried about brain injury, right? If it is pure neck injury and you don't think that they have any chance of any kind of brain or spinal injury, then yes, you can put them in Trendelenburg. But if you have any sense of brain injury, you don't want to put them in Trendelenburg, right? Because you don't want to increase ICP at all. But you guys understand why in a neck injury they put them in Trendelenburg? If you have a sucking wound. What do you do from a dressing standpoint? Occlusive dressing, right. And that should take care of it, except for they're still breathing, right? So they're still sucking in air, and they could put air into their bloodstream. So you put them in Trendelenburg so that if they put air into their bloodstream, it's not going to their brain. It's going to their body, where it's not going to be so detrimental. Does that make sense? That's the same reason why when we're putting in a central line and we're putting a needle into their internal jugular vein, we put them in Trendelenburg position. So if there's any chance that as we're doing all of these maneuvers and getting that central line in, there's even bubbles in the central line that weren't completely flushed out or whatever, but that's not going to the brain. And then when we initially put that in and flush it all through, it'll go to the body because the patient's in Trendelenburg. Same situation with a penetrating neck trauma. Does that make sense?
But with them in Trendelenburg, then the pressure is pushing more blood up to their head, isn't it? You still got pressure to their head, and that's why I'm saying that you want to make sure that they don't have a brain injury. But with the bubbles, wouldn't the bubbles kind of follow blood pressure to the brain?
The bubbles, especially in venous system, you've got drainage down to the heart and drainage away from the head and body, right? And bubbles will follow, or in blood are going to rise, right? So you put them in Trendelenburg and the bubbles rise to the body instead of down into the brain. Does that make sense? Now, of course, if it's in the carotid artery, Trendelenburg isn't necessarily going to help that patient because arterial pressure is going to be way greater than. Yeah. All right. We talked about seated. You guys know about RSI. Let's see. Fluid resuscitation, spinal shock patient. What do you want their systolic to be? 90. We don't need to talk about medications. Most of these medications you guys don't even have. You don't have steroids, you get dextrose. So, we talked about what the question about Gary's. I mean, here, book says use small doses in the head injury to prevent that should be to prevent hypoglycemia. And then you consult your protocols.
So it's just basically to keep their rotation up high enough that you know that's not a problem.
Right. So, and there's, in any kind of shock situation, your metabolism goes crazy. You can become hypoglycemic even if you are not a diabetic, even if you have a normal pancreas, if you have normal liver, everything else. In a shock state, patients can become hypoglycemic. In septic patients, they can become hypoglycemic just because their body's working so hard, they're using up all the glucose. The glycogen breakdown isn't fast enough. Sometimes you need to give them a little bit of sugar. You give them small doses in a hypoglycemic or to prevent hypoglycemia. That's why we put patients on D5 or D10 in the hospital, right? Because they're in a sick state. They have normal liver. They can control their sugars just fine, but when they're sick, their body doesn't do that all that great. The same thing happens with trauma patients. They're not going to control their sugars all that well. So honestly, I would err on the side of giving glucose rather than not giving it. I wouldn't withhold glucose because you're worried about increasing ICP. All right, you don't want to give them a quick bolus of D50. You want to give them small, frequent doses, right? Or put them on a drip. But I would rather err on the side of them having glucose than not having it. All right. 1 or 2 fluid challenges. We talked about that. Then you can consider pressors. Medications. List summary.
Can you go back to the drugs a little bit more?
Which ones?
Because like we've had several questions where it's like, okay,
You guys don't have mannitol, right?
yeah,
You guys do have mannitol?
well, we don't have it. We're being tested on it.
Oh, he's making you learn it.
Yeah,
It's only a secondary drug in case we see it, probably mostly because we see it in transfer, so, sorry guys.
Okay, that does make sense, and I can see the reason for it, that you guys might have to understand mannitol because it could have been given pre-hospital or being given during your guys' transport. So how does mannitol work? Osmotic diuretic. So what's its function to do? From the brain perspective, what is it doing? One person. Reduces swelling. Okay. So it decreases ICP, right? So it's drawing fluids from the trauma where you've got edema and everything else, brain swelling. It's trying to draw some of those fluids back into the bloodstream to get it down and out of the head. But mannitol is temporary. It only works for so long. You can't give it on a sustained basis. Research shows that sustained mannitol use or hypertonic saline, 3% saline, doesn't work on a chronic standpoint. They gave me hypertonic saline for like 10 days, and when I finally woke up, I felt like I'd been walking through a desert. It was ridiculous how dry I felt, and I couldn't understand why they had me on it for so long. And mannitol works. Like I said, it's transient. It doesn't work in a chronic situation, but your kidneys also figure it out really quickly and compensate for it, especially for 3% saline. A healthy young individual, 3% saline really is only going to work for about 5 minutes. Their kidneys will catch up and start spitting out all that sodium. Mannitol will work a little bit longer, but then your kidneys will open up and start spitting that out as well. Mannitol in an old elderly patient with crappy kidneys is going to work longer and be better. Look at that benefit of being old, right?
Kidneys quit.
You guys use fentanyl. You guys understand fentanyl. It is unlike morphine. What's a complication of fentanyl? We've talked about. What's that? Hypotension, yes. Less so than other narcotics, but it certainly can. What's that? Right. So rigidity, muscle rigidity, right? And yeah, chest syndrome from too much fentanyl too quickly causes that rigidity, and it's in the rest of the body, who cares, right? Because that'll come back and the muscles will be just fine. It matters in the chest. That's why they call it chest syndrome. It's rigidity everywhere, but we only care about the lungs because they stop breathing, right?
So would that affect the diaphragm?
Yeah.
Is that what it?
Yeah. It'll
The
affect.
lungs
It'll
are
affect. Yeah. It affects the muscles used to expand.
So if they're tubes, you can ventilate properly. They just can't. They couldn't breathe themselves.
Even if they're tubed, they get complete muscle rigidity. You can't get movement. So you can still put oxygen in, and that'll still help. Obviously, the alveoli might still be open, and you're still getting oxygen in, and you're getting pressure coming in and out, but you're not moving the chest. You're not getting very good respiration. So there's respiration and ventilation, right? You can still get some ventilation, meaning diffusion of oxygen and CO2, but you're not getting respiration. Does that make sense?
Right. So without getting way off track, why? I guess I would think it would go flaccid. Why does it cause rigidity?
The fentanyl?
Yeah.
It's a binding problem. You know, we talk about drugs that in certain concentrations they bind to certain receptors, right? And if you give them in too big of concentrations, they bind all the receptors, and then there's no inhibition. And that's, you know, how a lot of our paralytics work and everything else. And like dopamine, you know, in certain concentrations it does this. If you give it in too high concentrations, it starts to bind alpha receptors and other beta receptors, and it causes different things to happen. Well, fentanyl in the same way, that in certain doses or in reasonable doses, it will cause a relaxation. It blocks those mu receptors, so you get pain relief. And it can cause smooth muscle dilation, so it causes some hypotension. Well, in huge doses, you get there's no relaxation of those muscles, and you get rigidity. Now, I don't know the absolute chemical receptors that we're talking about binding. I'd have to look into that a little bit further. But in huge concentrations, it causes rigidity. So it's not a flaccid state. It's a more of a rigid state. Morphine, that's your common, that's like your classic opioid. Sedate, reduce anxiety, relieve pain, hypotension. That's that medication. Huge doses, it still does the same thing. That's why morphine is different than fentanyl. And they're chemically unrelated. They'll bind to the same receptors, but they're not the same kind of opioid. They're not the same kind of narcotic. You guys don't use diazepam or lorazepam. You guys do have Versed.
We have lorazepam.
Oh, you guys have Ativan? Okay. So Ativan is, how does Ativan differ from Versed? Thicker, you mean in like giving the medication? It's thicker. Lorazepam is thicker than Versed? See, I don't know how to. I just decide what to give them. I don't know what they look like.
Oh, you weren't asking me.
I don't know how they're given either. I just tell other people to give them. You do that. You draw it up. I want this dose. You figure out how to get